let's talk about MINDACT and how it was designed. I mean, Mark, do you want to kind of get into that a little bit?
So it was essentially designed as a non-inferiority trial, right?
Right.
Which is a slightly, I mean, it's a trial that allows you to have a smaller sample size, but perhaps is a little bit less tight in terms of confidence intervals. And they set the lower bar at, I think, 92%, right? That was thought to be the level at which you wanted to prove that the test segregated there. But the question that we're talking about now, which is the predictive value in terms of chemotherapy benefit, wasn't the primary endpoint of the trial. And so the thing that, in a sense, is of the most interest both to the oncologist and the patient is, I don't know if it was a secondary analysis, but it's an underpowered analysis. And so you can't draw the conclusion from the results that there was no benefit in the patients who were clinically high risk and genomically low risk. It's just you can draw the conclusion that the benefit is likely to be quite small. And then you wind up in the, well, what's small enough to forego it? And you wind up needing to have a conversation with patients, and which of course you always have to have. But some people think that 1 or 2 percentage point benefit in terms of chemotherapy benefit in that genomically low, clinically high risk group is worthwhile. And some patients will probably view that way as well, and others will not.
So just to kind of reiterate what this trial was, I mean, I think that it took about 6,600 women with early stage breast cancer, 0 to 3 nodes positive, and really almost any tumor size. It's interesting when you go back and look at the data, there probably were, I think, of the 6,600 women, probably somewhere in the several hundred that had tumors that were T3. So there were substantially big tumors. And the thing is that what they did is that they gave them a genomic risk, either high risk or low risk by the 70-gene assay, and they used adjuvant online, which we all know is not available. Unfortunately, adjuvant online is offline and has been that way for a while. And so I'm going to make a plea to Dr. Ravden, please give us adjuvant online. We've been waiting for it. I know you want to be perfect with it, but please give it to us. But nonetheless, they did a clinical risk based on adjuvant online. And if you were clinically high and genomically high, you got chemo. If you were clinically low and genomically low, you got hormone therapy. And so there was about probably 30% in each arm of those, that just 60% of the patients just were done. It was that middle group, obviously, that's the important one, where you were clinically high and genomically low. And there was about 1,500 women that were randomized to get chemo or not, or they randomized to use the clinical, so if you're clinically high, you got chemo, or randomized to use genomic. If you're genomically low, you got hormone therapy. And so the issue in that trial, as you say very well, this was not powered because it was $750 per arm to look at a chemo difference. It was a non-inferiority trial where they put their cutoff at 92%. They said if you were clinically high and genomically low and got hormone therapy alone, your 5-year distant metastasis-free survival, not distant disease-free survival, which is different because it includes a lot of local recurrence, but your distant metastasis-free survival at 5 years had to be greater than 92%. The trial was powered around that primary endpoint. And so the issue is, in that study, it was 94%. And then I agree, as a secondary endpoint, they went back and they looked at the benefit of chemo. And they found that there was no benefit, but it was powered to see at least a 1.5% benefit, which they could not see. So what does that 1.5% mean? And do you trust a non-inferiority trial? These are very good questions. But it is a prospective study, which we don't have much of. We have TAILOR-RX, which is a lot bigger. It's like, I think, 1,150 patients or something, 1,100, 250. It's a big trial. They reported already a year ago on the lower than 11, right? But they haven't reported the real meat of it, which is what we are waiting for. I think that may come out fairly soon, from what I understand. The fact that people who were intermediate risk were randomized to chemo or no chemo. Hopefully we'll see that data soon. But the question is, what should we do? I mean, I agree, all these trials are roughly the same in what they do. I mean, the indications seem to be a little bit greater, and we're going to talk a minute, I think, about the thing that was presented at San Antonio in a minute. But they all kind of do the same thing, I would agree.
Yeah, I mean, the way I've always approached this and the way I've talked to fellows about it is you kind of decide ahead of time what it is that you think you want to do with the patient.
Right.
And then you use the test to see if that's wrong.
Right. Well, and I think that that's the way we've been using it. But I think the other thing that came out of this that I think is really, really interesting is that it tells us not to do that. What MINDACT, and I think where I think we're going, and I'd love to hear your guys' opinions on this, because I know I have, as Kim knows, very strong opinions, and Kim, as usual, has very strong opinions opposite me. But the thing is that, which is a good thing, actually, it's not a bad thing. So the thing is that I think that what things like MINDACT do, and where we're moving, is we're moving away from that. We're moving to say, if you already know what you want to do, don't do the test. Come up with some clinical pathologic parameter that tells you. You know, maybe you have a low-grade tumor, 3 centimeters or less, that's node negative. You know, leave those out. Do the mammoprint, or if you have like a tumor with a Ki-67, if you use it of like 50%, you know, ER that's maybe like 10%, don't do it.
Yeah.
But it's those middle ones that the ones you want to do.
So I don't agree with you.
I know you don't, and I'm bringing this up. That's why we're talking about it. So what do you say? So let's hear it. Come on out with it.
I think women facing breast cancer deserve to have some type of prognostic genomic assay. So we could argue all day long, is there any predictive value in the MINDACT and, you know, the data that's been presented. But prognostically, I think that the genomic predictors help me in the clinic, because the tumors that we see it probably once a week, the grade 1 HER2 positive or the grade 1 ER negative, that doesn't make any sense. So we know that the biology of these cancers is probably way more important and is discongruent than the size and the lymph node status. So I would argue that even in T1, not in an 80-year-old, but in a 40-year-old healthy woman, she deserves to know the IQ test of her tumor. And this is where I've stopped guessing. So I don't actually, unlike Mark, I don't have a preconceived notion off of a let's take an average breast cancer, 2.2 lymph node negative. You know, I send the predictor because I've guessed wrong frequently, and a high 21 gene assay or a high mammoprint will change my thinking about those. I find them extremely helpful. I think as long as you understand how the test performs and the information it provides you, I think patients appreciate it as well. So I would argue that everyone needs the assay.
But Aditya, let me bring you into this conversation. At MGH, what do you guys do? Do you use, I mean, it's a resource allocation question. If you only have so many dollars to spend, you know, shouldn't we do it to the people who need it?
Giving chemotherapy is expensive. I just want to point that out.
And avoiding that is good.
Yeah, yes. But what if you avoided in the patient that would have benefited from it?
Well, we'll get to that. I agree.
That's the oncologist dilemma.
I agree with that.
How many people do I overtreat every day?
I agree. What is your guys' thoughts on that?
I think it's a tough question, and we have debated discussions like this at our tumor boards. I think there are a couple of things that I would like to highlight. If you look at the validation of Oncotype DX, the original NSABP paper, in that, grade was an independent predictor of disease-free survival. And if you look at the hazard ratio, it was actually even more than Oncotype score. So I think grade does have its own value that's independent of what the Oncotype DX shows. So I agree with Kim that I think it's very helpful to get information that we can provide to the patients as long as we believe that the information is accurate. So for patients who are premenopausal or young or less than 35 years of age, we don't have the same level of evidence as compared to someone who's postmenopausal. So I think we just have to be careful when we order the assay that it's ordered in a setting when we get the results, we can trust the results and we can believe that the data is accurate. The second point to consider is that all these assays are proliferation assays. And there has been interest in just looking at Ki-67 and this IHC4 developed in Europe, which looks at ER, HER2, Ki-67. And a recent paper in JCU also from the Hopkins group, which said that, you know, number of physicians can guesstimate what the recurrence score is going to be. And if you look at standard clinical pathological characteristics that are that essentially can help you make a decision about who needs chemo versus not. So I think there's a lot of value in clinical pathological characteristics, but when there's a case like Kim was mentioning where you have a grade 1, but you feel that the biology is not reflective in grade 1, I think for cases like this, it's very reasonable to get additional data so you can make a decision whether you should give chemotherapy versus not.